There is an announcement. Masterclass Track 2 under the topic Mastering the Art of Scientific Presentation will commence at 2 p.m. at The Connect. Those who have registered, please proceed. Our next expert discussion focuses on one of the most prevalent challenges in modern cardiology. Please welcome the chairpersons, Dr. Bandusiri Ratnayaka and Dr. Shashi Karuna Ratna.
Good afternoon, ladies and gentlemen. It's my pleasure to introduce our next speaker, Dr. Jitendra Bamecha, MD, MPH, MACP, Associate Professor of Clinical Medicine, Cooney School of Medicine, New York. Dr. Bamecha is going to talk about understanding of heart failure with preserved ejection fraction, new insight into a growing challenge. Now I cordially invite Dr. Bamecha to the podium.
All right, good afternoon, everyone. Looks like the lunch has been very, very good. But nevertheless, we have to be in time. So thank you for the good introduction. My mom will be very happy. Thank you, Sri Lanka College of Internal Medicine, for having me here. This is my first time in Sri Lanka, and it won't be the last time. I'm coming back in next February since we are hosting World Cup cricket. That's my favorite sport. So today's learning objectives are the following. Reviewing the prevalence, definition, and diagnostic criteria for HFpEF. It is extremely important how we define this particular area in cardiology, and identify some of the mimickers of HFpEF, and then we'll discuss some of the therapies. They may be novel or they may be on the horizon. So let me first start with the definition. Just after COVID in 2021, several cardiovascular societies across the globe came up with the definition. It's a clinical syndrome with signs and symptoms caused by a structural or functional cardiac abnormalities, and the collaborative findings are the increased BNP levels, as well as objective evidence of pulmonary and systemic congestion. Not too long ago, in 1933, Sir Thomas Lewis, he mentioned the very essence of cardiovascular practice is the early detection of heart failure. So we are here almost 90 years, and we have come a long way in terms of not only defining various types of heart failure, but also the treatment as well. And I'll go into details about how we came up to the newer nomenclature on heart failure. These are some of the framework where we classify heart failure, whether they are based on symptoms, which is New York Heart Association 1, 2, 3, 4, or based on the ejection fraction. So today's topic is based on ejection fraction, preserved heart failure. But there are other classification framework, which is based on etiology. All the three layers of heart, which is the endocardium, pericardium, and myocardium. And how this disease progresses, also there is a revised nomenclature of stage A, B, C, D. Then the next two are a little bit more advanced, not purview for our today's discussion. One is on the phenotype, which is the emerging science around the heart failure overall, and we'll be hearing more and more in near future. Last but not the least is those who have advanced heart failure, either on assist devices or waiting for cardiac transplant. Again, to summarize, these are the typical classification framework for the various types of heart failure. As I mentioned, on the stages of heart failure at risk, that means these individuals do not have any signs or symptoms of heart failure as such, and they also do not have any structural or biomarkers associated with heart failure. These are called stage A. Most commonly, comorbidities are the hypertension, diabetes, and obesity, or maybe a family history of cardiomyopathy. By and large, very large population on stage A. When we come to stage B, in this also group, individuals do not have either current or previous signs or symptoms of heart failure, but they do have some structural or functional abnormality in the heart, and also on the lab increased BNP levels or so forth. Stage C, which is towards the progression of the end stage, where not only signs symptoms are present, but you do have the structural and functional cardiac abnormalities. And if we treat, some of them go into remission, but majority of them do go into persistent heart failure, which is the stage D. Now, as I mentioned, today's discussion is mainly focusing on the ejection fraction, where we calculate during the echocardiogram. Many of the critics that this is not the perfect method of identifying patients who have heart failure, but nevertheless, the newer guidelines do base their therapeutic interventions based on the ejection fraction. So by definition, heart failure with preserved ejection fraction, the ejection fraction has to be above or equal to 50% on echocardiogram, plus the evidence of lab markers, which is the BNP and invasive or non-invasive hemodynamic measurements, which will go more into details. Looking at all the various types of heart failure, whether it is reduced ejection fraction or mildly reduced ejection fraction or preserved, the main difference between the reduced ejection fraction and preserved is reduced one is the systolic dysfunction, whereas ejection fraction of more than 50 or equal to is mostly diastolic dysfunction. Again, this is an older terminology. Today, if you have to learn one thing from the session is, please remember, preserved ejection fraction is nothing but diastolic dysfunction plus comorbidities. So if we can take care of all the comorbidities which is related to preserved ejection fraction, we'll achieve our treatment goals. And the second finding in the preserved ejection fraction is the stiffness. So their ventricles are small, the atrium size is small, they are very stiff, and the filling pressures are high. Very, very simple. Whereas in the reduced ejection fraction, this cartoon, although I'm not supposed to provide any cartoons during the ACP, but I hope they will forgive me. But this is a very good way, infographic on how we differentiate between the reduced ejection fraction and the preserved ejection fraction. As you know, the reduced ejection fraction, the heart is like a balloon which is inflated, whereas in the preserved ejection fraction is thick and stiff. So coming back to the definition and criteria, as of today or last week, I was looking at the ACC and other guidelines. We do need to have a signs and objective signs and symptoms. And also the structural or functional abnormalities. In terms of lab, very important BNP and anti-pro-BNP, and I was speaking to some of your colleagues, they do in the private hospitals BNP and anti-pro-BNP. Earlier this morning, Dr. Uppu was mentioned regarding a class of medication, ARNI, very important in terms of ACS and blood pressure control. So if the patients are on ARNI, please do not do BNP, please do a pro-BNP, because neprilysin, it inhibits the BNP in the kidneys. Last but not the least is the objective evidence of cardiac or pulmonary or systemic congestion. Again, in terms of phenotypic variation, where we practice in North America, most of the patients are obese and they have a very high prevalence of diabetes and frequent hospitalization due to heart failure. But that is not true when you go to South America. They are increasingly younger population and they do have other comorbidities and they have less hospitalization for whatever reasons. If you come to this part of the world, mostly young and lean pattern, especially in the Asian population. I was trying to Google the prevalence of Sri Lanka. I could not find, but I think it fits well into visceral obesity, which we heard last night. and also the increased heart failure hospitalization. And if you look at Western Europe, these are elderly population and they have more frequent atrial fibrillation. Again, these are based on number of studies which was published last year. So globally, overall, the incidence of heart failure as such is stable. If you look at the Framingham heart study or cardiovascular heart studies, the incidence of reduced ejection fraction is decreasing by and large because of modern therapies. But the preserved ejection fraction is moving in the wrong direction. I guess that was the reason the council member chose this particular topic for discussion today. And if you look at globally, I was very surprised looking at Taiwanese and Portuguese. They have the highest, almost 7% of population, they have heart failure because of obesity. So a quick glance, heart failure, it involves 65 million. It's a global public health problem. As we age, more and more above 65, the 70% of heart failure will be based on preserved ejection fraction. And it is becoming the dominant type. The 5-year mortality rate is between 70 or almost 50 to 75%. And one of the interesting factor is those who have preserved ejection fraction heart failure, they're lower risk of all-cause death than people who have reduced ejection fraction. But on the other hand, they have non-cardiovascular disproportionate cause of death. About 20 years ago, obesity became the largest risk factors, not only in the North America, but also globally, and it is going to increase. By 2030, that will be the number one comorbidities which will be having the greatest burden on the preserved ejection fraction heart failure. In terms of systemic consequences, it's not only confined to the heart. Think of this as a systemic illness or very heterogeneous. It involves brain, cognitive impairment, reduced gray matter, lungs, obviously, towards the end stage is the pulmonary hypertension and reduced diffusion capacity. Obviously, we'll talk more about heart. And also in kidneys, it activates the RAS system, the reduced renal perfusion, and in the peripheral vasculature, especially in the microvasculature and the macrovasculature, it causes dysfunction and arterial stiffness. And last but not the least, in the skeletal muscle. So it's a systemic illness. In terms of hemodynamic congestion, it is very different than reduced ejection fraction, although there are several factors which increases the wedge pressure and as well as end diastolic left ventricular pressure based on the atrial and ventricular diastolic dysfunction in terms of hypervolemia or stressed or increased stressed volume, and also increase afterload cardiac dysfunction. But not all individuals will have all the pathophysiology profile. So initially at rest, patients may feel fine, but only when you ask them to do some exercise, you will see some of the pulmonary vasculature pressure goes up. So most of the diagnosis is based on patients usually have either dyspnea or exercise-induced left atrial hypertension. And when it progresses after a few years without any proper treatment, these individuals develop paroxysmal or intermittent atrial fibrillation. And towards the end, what you will see is from the mitral regurgitation, it will go into more of tricuspid regurgitation and the intermittent atrial fibrillation. Because of the dilatation of the left atria, you have atrial fibrillation as a common EKG findings. So in terms of phenotypic prevalence, if you look at all the individuals of heart failures above, ejection fraction above or equal to 50%, by and large, HFpEF is one of the most common one. But within that framework, you will see that not a single pathology is more prevalent. So it's a combination of multifactorial, it's more heterogeneous. That's why the treatment is also focuses on the heterogeneity. These are three buckets. If almost 80 to 90% population of preserved ejection fraction will have hypertension, they have a very different phenotype, and the pathophysiology is very different as well. But those who have clearly microvascular inflammation, their pathology is a little bit different. And the third group is both the combination of hypertension and other microinflammation or obesity as such. So again, the treatment is very different in all these phenotypes. In terms of evaluation, anyone who has been suspected of heart failure, these are the battery of tests we ought to order. CBC with differential is very, very important to make sure that these are not anemic. Anyone who has elevated leukocyte or neutrophils and lymphocyte, they are poor markers. They have a poor prognosis at the time of diagnosis. For basic chemistry panel, mostly to identify eGFR or the renal function. And for liver function, towards the end stage when they have right-sided congestion, you will see some findings on the liver exams also. BNP and NT-proBNP, I'll go a little bit more in detail. These are not only to evaluate or part of the classification, but there are conditions where these are extremely low. Almost 30% of individuals with preserved ejection fraction either are deficient or low BNP. So it cannot be the sole lab test for the evaluation of heart failure. In terms of high sensitive troponin, be careful. Those who have minor elevated of troponins, it could be myocardial phenotype variety of heart failure, or it could be amyloidosis, or which we call it mimics of heart failure. In terms of uric acid, this is a good marker of people who have gout and other kidney dysfunctions. In terms of SPEP or UPEP or serum-free light chains, mostly geared towards the plasma cell dyscrasias or the renal dysfunctions. One thing there was an error is the pre-albumin also. The reduced level of pre-albumin gear more towards the amyloidosis type of mimics of, they have a preserved ejection fraction. In terms of iron studies, anemic patients, we have to make sure that the anemia is taken care of. TSH is very important because both hyper and hypothyroidism can mimic as a preserved ejection fraction heart failure. For autoimmune, ANA screen is good. Whereas other markers for secondary hyperparathyroidism is the intact PTH, 25-hydroxy cholecalciferol, and calcium and phosphorus. Urine albumin creatinine ratio is a surrogate for poor renal function, and if it is positive, then make sure that these individuals are on either ARBs, ACE inhibitors, or ARNIs. Obviously, hemoglobin A1C, which is when it is high, we have to make sure their A1Cs are less than 7 or 8, depending on the age group. Last but not the least is lipid profile. One point of those who have hepatic congestion or end-stage heart failure, please do not look at their lipid profile solely. In those cases, you should check ApoB in those individuals. Some of the clinical pearls, continuing with Dr. Ganaka and Dr. Upu this morning, focusing on the clinical exam. As I said, most of them do have hypertension, but many of them will have irregularly irregular heart rate because of the high incidence of atrial fibrillation. If you see peripheral edema or abdominal fullness or anorexia or early satiety, that more towards the right-sided failure. If a patient complains of dizziness and orthostatic hypotension, think of amyloidosis, which is a good mimic of preserved ejection fraction heart failure. In terms of EKG findings, increased PR interval is a very significant and potent finding in terms of preserved ejection fraction heart failure. And last but not the least is cardiomegaly and the pleural effusion. So as I mentioned, if you look at the on my right or left, at rest, the wedge presses are normal. As soon as you ask them to do some exercise, the wedge pressure increases. And this is like when you are in the beginning of the heart failure symptoms. But as without any proper treatment, or if they go unnoticed, you will see changes in the echocardiograms and finally in the physical exam, S3 gallop, which was another question which came in the previous talk today. So it is very, very important to look at the patient, ask for medication history and signs and symptoms, and also the radiological findings. Once they develop S3 gallop, it's a very stage C or stage D in these individuals. In terms of BNP, there are other conditions apart from heart failure where you will see the increased BNP levels. Again, this is a very exhaustive list. Make sure that BNP cannot be only looked at to evaluate heart failure patients. If it is negative, then probably it essentially rules out, but there are some conditions where the BNP could be lower. And there are some non-cardiovascular causes as well. Of note, these are the individuals where you will see the low BNP level. Obesity, surprisingly, will have low BNP levels. So be careful if an obese patient is coming for your evaluation for heart failure. Those who are from African ancestry, those who have insulin resistance, those who are using corticosteroids, especially for COPD exacerbation or other medications, please be careful when we are looking at the BNP. And last but not the least, any small cavities or left ventricular hypertrophy may give you some misleading findings. Next slide is a little bit very busy. I don't think in the end those who are sitting in the back can look at it, but what I mentioned regarding the clinical lab and imaging, these are some of the predictors. Not a single test is 100% sensitive and specific. But based on the physical exam, hypertension is very specific, whereas in echocardiogram and EKGs, there are some levels of sensitivity and specificity. As I said, none of the tests are 100% sensitive and specific. None of them go even beyond 70% of sensitivity. In our general practice, we do mostly echocardiogram and the BNP or pro-BNP. And if you look at this graph, again, the echo is very specific, but it's not very sensitive, whereas BNP is highly sensitive, but not very, very specific. Those who are cardiologists or those who do echocardiograms, these are some of the findings which are very prevalent. I will only focus on two, which is very important for the diagnosis of preserved ejection fraction heart failure. One is the E ratio, tall letter E and the small letter e, which is the early diastolic mitral inflow velocity over annular tissue velocity. At rest, it should be more than 9, but as soon as the patient is exercising, and if it is more than 13, you get a diagnosis, and also the pulmonary artery systolic pressure more than 35. And if you look at the cavity size, as I mentioned, the reduced ejection fraction, they are a big cavity, they're enlarged, whereas in the preserved ejection fraction is more smaller cavity size and stiff. This is the gold standard for the diagnosis of preserved ejection fraction heart failure. So during the right side of catheterization, if you make the patient exercise, more than 15 at rest and more than 25 on exercise, wedge pressure confirms the diagnosis. I will not go into the details about the clinical pathways of suspected heart failure due to time constraint, but if the patients are hospitalized, please, those usual tests can be performed, lab test and the EKG and chest x-ray and echocardiogram. But those who are working in the emergency room, BNP, which is the wet because of the congestion, could be very valuable, and those who are working in the office or the ambulatory care, you can start with the pro-BNP as well. Now, once you have all the blood test and the other echocardiogram findings, there is a risk scoring. There are two major risk scoring criteria. One is H2FpEF and the other one is HFpEF. But non-invasive wise, and mostly in our clinical practice, we use H2FpEF. It is one simple step. You don't need BNP. All you need is the echocardiogram, and based on the patient profile, you can come up with a score. So 0 to 1, you can essentially rule out, and anything more than 6, it goes towards the diagnosis of FpEF. And those who are in between, you can go. They can go for exercise, either echocardiogram or right side of catheterization. There are some mimics of the preserved ejection fraction. Again, it's an exhaustive list. I don't want to go into the details, but remember there is a role for cardiac MRI in these individuals, especially those who have hypertrophic cardiomyopathy or cardiac sarcoidosis or cardiac amyloidosis. There was an interesting study from Mount Sinai in Manhattan that there is a group of South American individuals in Queens. They are seeing the increased rate of cardiac amyloidosis. So please, if you happen to be practicing in those type of neighborhood, please think of beyond the regular vanilla of preserved ejection fraction. Again, this is, I'm sure all of you know about the pathophysiology of how RAS and the neprilysin, they work, and the treatments are based on those particular diagram on how they interact. This is the newer guidelines. It was about 2 years ago it came out, and there are a couple of changes in the this year as well. There is an update from ACC. Again, everybody should be on the SGLT2 inhibitors regardless. Even if they have congestion, initially you can give diuretics, but once the congestion is a little bit over, all of them should be on SGLT2 inhibitors. Getting into more specificity, if you want to reduce their congestion, you can use the loop diuretics, and the other medications are mineralocorticoid and ARNI and ARBs. Word of caution, we have to take care of the comorbidities in all these individuals, whether they have diabetes, hypertension, CKD, obesity, atrial fibrillation, sleep apnea, and COPD as such. These are some of the class of medication. These are the newer medication which are not part of the guidelines, but they are coming very soon. The glucagon GLP-1 agonist semaglutide and GLP-1 and GIP agonist, which is tirzepatide. And last but not the least is the newer non-steroidal MRA, finerenone. They will be included in the newer guidelines. These are some of the studies which led to use of GLP-1 in heart failure as such. These are some of the contraindications. We have to be very careful, especially type 1 diabetes and people who are on dialysis. We should not be using SGLT2, and MRAs and others. Obviously, all of you know that potassium more than 5, we have to be, those are kind of absolute contraindications. And pregnancy. These are some of the ineffective therapies. It does not work based on the current guidelines. We have nitrates, phosphodiesterase 5 inhibitors, digoxin, and the newer medication is endothelin antagonist. They do not work. Please do not prescribe. Some of the device-based therapies, those are only good for monitoring, especially the implantable in the pulmonary artery. You can use your smartphones and you can monitor these patients to reduce hospitalizations. Rest, these are all for academic purpose. None of them are being used. More and more studies have to be done to make sure that this becomes the part of clinical guidelines. Very quickly, these two individuals are very, very similar in the profile. The only difference is the physical exam. One person has carpal tunnel syndrome and lumbar spinal stenosis, but other than all the profiles are same. So individual B is amyloidosis. It's not the patient which we are thinking of. So again, remember what Dr. Ganake mentioned earlier today, to focus on the physical exam. When do you refer this patient to cardiology? Check-in is the acronym. And then for the advanced heart failure patient, those who need transplant, you can send them to heart failure specialist if you have one in your area. This came out last month, about 2 weeks ago. This is a hypothesis. It has not come into the market yet. The visceral obesity, very, very important in Asian population, in India as well as in Sri Lanka, gear more towards the inflammation on the visceral adipose tissues, which is the adipokine. And we will be seeing more and more selective adipokine modulators in this particular group of individuals. So that will be coming perhaps in another year or two. Last but not the least, any session is not finished when we don't talk about AI. Again, most of them are research purpose. Some of the AI tools which have been used are in the echocardiograms and the EMR data, and also the EKGs, which can diagnose even better than the human eyes in some of the instances. So again, AI tools only can enhance the precision of the diagnosis. It can enable the identification of novel phenotypes. Again, phenotypes, not every individual is same. Based on the phenotypes, we have to curate the treatment. This is in summary. I'm sorry I have to rush to the slides. If you want to learn today, only a couple of things. It is going to be very, very predominant as we grow older, and it will be very, very common in females. And in terms of left atrial measurements and obesity, they are the better predictors for risk stratification. So it's no longer a heart disease. Think of it as a metabolic inflammatory disease. That would be my summary slide. And last but not the least, if I have the permission, I want to ask one question from the audience. And these are two of my favorite sport. As I said, I'm coming back again in February next year, but it is for the World Cup cricket. And the next summer also we are hosting World Cup soccer. So if anybody is interested, please let me know. So when is the World Heart Day? This is the question for the audience. Anybody knows World Heart Day? We celebrate so many. So it's, I had a gift for someone who could answer this. September 29th every year is the World Heart Day. So with that, I want to conclude and any open to questions. I apologize, I have to rush through because of the time constraint. 30 minutes does not justify such an important topic, and it is going to be more and more prevalent.
Thank you, Dr. Vermacha, for that excellent presentation on heart failure with preserved ejection fraction. On behalf of the Sri Lanka College of Internal Medicine, I cordially invite my co-chair, Dr. Bandhu Siriratnayaka, to hand over the certificate of appreciation to Dr. Jitendra Vermacha.